First of all, thanks, Terenti, for the brief introduction, and good morning, good afternoon, good evening to all the participants and the audience, based on wherever you're located today. So, a little bit of background about me. I am currently the co-founder and director of one of the health tech startups based out of India. It's an early stage startup. It's Peco.ai. Prior to this, I had a, close to a 20 years old career in management consulting and strategy, and out of which 12 years in healthcare. I have worked with companies like Accenture for a long time, and then with Cognizant for a shorter stint as a healthcare leader in their management consulting practices. And I'm also an investor in some of the insurtech companies that have a focus on healthcare. Now, that said, my experience in healthcare spans the global markets. In fact, I have worked for clients in the US, UK, Hong Kong, Middle East, and obviously in India. And what I'm going to talk to you about today is digitizing healthcare at the grassroots level. When I say grassroots level, I'm typically talking of the primary care in healthcare, because grassroots could have multiple interpretations and connotations. So I'll remain confined to that. Now, that said, let me go for the presentation right away. Now, I talked about this, and when I say digitizing healthcare at the grassroots of the primary care level, it's not so simple as it sounds. But I'll try to break down what I'm going to talk about, and I'll try to limit my talk to about 30 minutes, so that we leave a little more time for question and answers. I understand that this topic is more of set of dialogues rather than a monologue. Let me get started on this. Now, if you look at the current healthcare system today, and as most or all of you would acknowledge, it's broken. And having said that, digitalization initiatives have started over a period of time, and they will continue to accelerate, and they definitely hold the promise to a better healthcare. But when I say digitalization, it's across healthcare. But one area which is actually still continues to face challenges is healthcare at the primary care level. And that poses problems for the activities that are downstream. For example, it leads to secondary care, tertiary care, and all those things, which are adverse events. Now, how do we look at rapid and actionable digital efforts at the primary care level? And that could be a game changer. Now, that said, it's not that things haven't happened in primary care level. There is concerted efforts by governments, there is efforts by private organizations, there's effort by health systems, and a bunch of startups that have joined the race. But it needs to be more practical, more sustainable, and more outcome oriented. Now, as I get to I'll bring about the nuances of this. And as I get closer to the end of my call, I'll be focusing on the what and how that needs to be answered to make digitalization at the primary care level or the grassroots level, as I say, a reality. So that's the essence of what I'm going to speak to you for the next 25, 30 minutes. Well, if we look at the situation today, the highlights first. Now, healthcare there are several good strides in healthcare, and one of the phenomenal things that have happened in healthcare has been rise in specialist care amidst advance in technology. There has been proliferation of digital initiatives. There's actually telemedicine and virtual care have progressed quite fast, and have hit the roof, accelerated by the pandemic. Artificial intelligence is finding its place in several forms and nuances, both in assisted diagnostics and therapies. You might talk of cancer, talk of cardiovascular diseases, or any other thing for that matter. Now, there have been several initiatives around value-based care. When I say value-based care, that's in the US parlance, but it's typically more, you can say, outcome-based care or outcome-driven care. There is increasing focus on social determinants of health. So, what has been shown recently or through academic studies, if not anything else, is there's a huge bearing on health, not just on the health parameters, but where we live, where we work, where we play, where we worship. And these things have got a lot of bearing on health. And finally, there's a lot of thinking and efforts around moonshots, such as precision medicine, evidence medicine, to just name a few of them. Now, these are some of the massive strides that have happened in healthcare, and these will continue to, bear fruit and continue to move forward and continue to gain more traction. But on the other hand, if you see to the right, a lot of the things remain unsolved. For example, affordability, access, and transparency continue to be challenges despite all the good things that I just spoke about. Inequity in care remains despite these things. When I say inequity, it's inequity across the globe. Inequity is driven by geographies, inequity is driven by the ethnicity or the race of population, amid other things. Now, there are gaps in care delivery across the continuum of care. Care today seems to be kind of disjointed, not an integrated set of activities. Primary care has taken a backseat because of due to the advent of specialized care, specialization in care, and that is actually leading to adverse impacts, which I'll take to in the next slide. And all these leave a fractured experience both for the health consumer and the health provider. Now, as I'm talking through all these things, I'm not talking about one country or two countries. I'm talking in general across the globe. And as a case in point, if you see, I take the case of examples of two markets. One is the advanced market, such as the USA, and on the right-hand side, you have a developing market, such as India. Now, if you look at the statistic, today in the US, almost 18% of GDP is the healthcare spend, which is the highest in the world. Fraud, waste, and abuse is phenomenal, like 25 to 30% of the annual healthcare spend. 80% of the healthcare spend is attributable to population having one or more comorbidities. 35% of the emergency room visits are avoidable. There is tremendous amount of physician burnout despite electronic health records that have been around for quite some time. Inequities and other clinical issues in telemedicine, which is already rising, but inequities remain depending on the localities, the geographical differentiation and all that. Now, I talked about value-based care, which is being increasingly adopted by the healthcare providers and payers to bring down cost and bring efficiencies in the system. But if you look at the true success, it's really limited to single digits if you look at in percentage terms. Now, if you go to a developing market like India, the healthcare spend is very little. It's like close to 4% of GDP, which is very low. India is the diabetes capital of the world. Electronic health record, health information system adoption are at very low levels, and there is wide inequity in healthcare. Primary care is typically limited to government facilities. The shortage of doctors, nurses, beds, and other infrastructure continues to be a problem. And because of this lack of unified data and EHR adoption being low, things like telemedicine and virtual care and all becomes uncertain, if not difficult. Now, the reason I'm trying to drive home this point is, despite the advance made in healthcare, both in across the world and across any country for that matter, there are systemic challenges that remain, and a lot of that stems out of the fact that we are not doing things right at the primary care at the basic rudimentary level. Now, despite all these things, and fueled by growth in smartphones, easy access to information and all, the health consumer and health provider expectations continue to rise. Now, when I say expectations continue to rise, I mean it's across the board. For example, it doesn't matter whether you are a uber rich customer or a health consumer or someone who's in the middle strata of the society or someone is not so well off. And similarly, when you look at the health provider side, it's not about the best kind of hospitals or the specialists, but also there is increasing expectations from the primary care physicians, the family medicine practitioners, the internal medicine specialists, just to name a few. Now, if you look at the health from the health consumer perspective, Access to the right form of care is one of the key expectations or key demands, and rise in on-demand care is increasing exponentially. And that's one of the things why telemedicine is also going up. Now, affordability is getting questioned, and people are questioning about the transparency. It's is healthcare where the treatment can be of the cost of treatment can be predicted, or is it going to at the end of my care, I know that this is the bill. Consumers demand retail-like experience, learning from the way they shop, the way they book a cab, or the way they order things for their for their domestic needs. Convenience in any setting is becoming more grounded. Consumers expect continuity of care and convenience through a connected ecosystem, not like, I am left in the lurch after every episode of care. Next, where I'm going is kind of a black box for me. Empowerment with the right and curated information, and wellness. Now, if I look at the health provider point of view, including the GPs, PCPs, and whatnot, integrated patient information that's synthesized and appropriate to the case, and which leads to optimized clinical encounters. Electronic health records that are extremely simple and enable them rather than causing burnouts, which is happening to a large extent today. Flexibility and enablement to choose the right model of care driven by information and synthesis of that, whether it could be physical or whether it could be virtual or what should be done first. Now, having said that, there is gaining acceptance of artificial intelligence tools, but they need to have an empirical evidence. They need to be proven, and the physicians need to be sure that the element of bias is reduced. Now, at the center of all these things is technology, which is just a click away. It's not something which I'll make things happen by using technology, but technology should enable me to do that and should be just at the click of a button. Now, this is the scenario today, the good things that have happened in healthcare, systemic challenges that contain amid the rising expectations of both the health consumer and health provider. But see what's happening. If you look at the customer journey and care delivery, at the basic level, it remains broken. Now, this is a slide which obviously is a patient journey, and I won't read the text, but let me explain to you what is happening over here. There's a patient aged about 60 years who complains of dizziness and general weakness, takes help of a helpline or a digital app or to the app provided by the insurer, and gets connected to a physician that's several miles away through a teleconsult. Now, in the absence of a structured EMR or EHR and physical checkups, only a provisional diagnosis is done. The physician potentially thinks that there's no necessity of a follow-up, not because it's not needed, but because sufficient information is not there. It's kind of on-demand care which has happened at convenience, but it's deprived of this. And now the patient takes the medication, but things worsen, and then there are several episodes of care, and finally you move to the large red button. After several episodes of care, there's a patient lands in the emergency department with a stroke. Now, the point that I'm trying to drive home here can this be avoided? The answer is yes. And what are the inefficiencies that have actually crept into the system? For example, starting with access, which is in the gray box, the access to the right doctor and access to the right model of care is probably not right over here. And similarly, because there is lack of information and provisional diagnosis is done, lack of integrated or interoperable EHR, there are episodes of care in which there is duplication of tests, duplication of what I would say other things, and finally there doesn't seem to be a well coordinated care or case management, and all these have led to finally the patient landing in the emergency room. So typically what has happened is a case that got presented at the primary care level, due to several inefficiencies and several challenges across the patient journey or the touch points, have resulted in secondary or tertiary care, which is added up to inconvenience, rise in cost of care, and even inconvenience to the treating clinicians or the physicians in the hospitals for that matter. So the point is, can technology make things better over here? Can technology fix nip the problems in the bud as we see it in this model of primary care moving all the way to secondary or tertiary care? And if so, how and what and how can it happen? So that's the key question that I'll be delving into as I go into the next slides. So before that, we talked about some of the good things that have been happening in healthcare. Just to recap that, I want to make a quick summary of the digital initiatives that have been happening for some time. COVID-19 has accelerated that. One is there has been a rising adoption levels of electronic health records and HIS. When I take at a global level, typically the advanced countries, there are concerted efforts towards interoperability and meaningful use. There is proliferation of digital apps and enough funding available both for patient and clinical facing apps, as well as apps that get into big data kind of stuff. AI assisted clinical decision support there have been several ongoing efforts and successes in oncology, cardiology, and other specialists. Efforts around moonshots such as precision medicines and evidence-based medicines continues to take center stage, not just within any localized entity, but across the healthcare ecosystem. A lot of things are getting, like, for example, a lot of point solutions are emerging around connected care, marketplace features that probably make life convenient for a health consumer, disintermediation, like providing access health coverage to those who are needy and don't have coverage from either the government or their employers. So those things are happening. And there is increased focus on studies around and capture of social determinants of health. So these are the things that have been happening for some time, and COVID is in fact accelerating that. Now look at, if I go to how, we take some of the learnings, build use cases for primary care, and make it a success with focused and pragmatic steps. Now, I have 7 themes that I could think through, analyze, both from my experience as an entrepreneur as well as my experience as a healthcare consulting leader, having worked with several clients across the globe. And I'm going to delve into that. But before that, there are a couple of assumptions or a couple of premises that I would like to state. The first thing is, digitization of primary care is one aspect of uplifting primary care. There are several factors, like, for example, the government regulatory mechanism, the business models that come into play, the investments that get done, who does it. For example, a mix of the government and private entities or the startups joining hands and making this a success. And digital is going to be an enabler. Obviously, my theme or my area of focus is going to be talking about the digital aspect. But having said that, all these things that I talked about play an important role. It's just not digitalization, but digitalization is an important enabler. Now, that is one thing. The second thing, as I speak through each of these points, what you would find is there's a lot of skew towards clinical efficiency, or making the clinicians or the health systems more efficient. Well, as I state that, what I'm not trying to do is not, belittling the importance of patient-facing or consumer-facing technology, because that's also very important. But the problem is you can do only as much by empowering or enabling them. It is imminent that the clinicians or the health systems or whatever form they are, or the caregivers, get empowered, enabled, and facilitated to make an impact to the patient or the health consumer. And that's where these are the 2 premises that I had. Now, as I delve into what I have on my recommendations or my point of views, or rather open questions which each of you could think about how to apply, it will be valuable. So, for example, the first thing that I could think of is beyond interoperable EHRs and towards meaningful use. It's not that interoperability has been achieved fully as yet, but there are efforts and it will happen. But beyond that, where should we go? How do we make meaningful use of the EHRs possible? How do we reduce the burnout? There are a lot of things like voice recognition, process mining, data mining within EHRs. But in my view, a synthesized EHR, which is appropriate and simple to use and relevant to the case, makes sense. For example, you land up with a primary care physician with ailment like, I'm having issue with my stomach, versus I'm actually landing up in a PCP with an issue as I'm having general weakness, fatigue, and vertigo kind of things. Well, the information that needs to be presented before the physician should change, and that would actually lead to the care part, the uh, decision making the clinician makes when he doesn't, when he is doing a clinical encounter. Now that's the first point. Now, the second point which I want to highlight is person generated health data. When I say person generated health data, it's not just through wearables. I'm looking at the entire gamut of population. It could be through wearables, it could be through community health efforts, or it could be through Internet of Medical Things. But having said that, this is going to be real-time data, which if integrated with the EHR will make both the diagnosis, consultation, and the path of treatment simplified and meaningful. But having said that, there is a lot of skepticism when you take this to the the healthcare providers, the physicians, or whosoever it is. The reason is they have several questions like, is the data, what's the provenance or origin of the data? Is it taken in the right setting? Can I look at this with the same level of confidence when I do a physical examination of a patient in a clinical setting? So that said, how can technology be used to not just easily capture the data, but filter noise out of it and seamlessly integrate it with the EHR? Then it becomes a case for point to make decisions, which we call decisions enabled by real-time information. Now, the third thing that I have here is clinical decision support. Now, clinical decision support systems traditionally have been a gray area between the EHR vendors who are trying to provide that and trying to embed it within their EHRs. And at the same time, there is a gamut of players outside who are trying to look at clinical decision support in various forms and ways. For example, we talked about AI-assisted diagnostics and therapies in some of those specialties. Well, that's a great example of artificial intelligence in care. Or, for example, checking whether you are diabetic or not through, using technology and looking at your retina could be another great example. But what I'm trying to emphasize here is, well, that's important, but that's not just getting into specialties. Let's think of clinical decision support, which is provided across the patient journey and across episodes of care. For example, based on the acuity of the patient and based on something that's convenient to the patient to answer, can there be an appointment triage done using symptom checkers in a very, very systematic and what I would say algorithm-driven way, which would lead to optimized encounters, and care pathways? Can the follow-ups be triaged based on not just acuity of the patient, but the general condition of the patient? Someone may be a elderly patient who may not be able to understand things so well, so the follow-ups have to be coordinated in a different way. And same applies to remote monitoring. In what setting is the remote care monitoring provided? What is the education level of the education and other factors of the patient that remote monitoring? Now, what I'm trying to say is clinical decision supports needs to expand across the patient journey and episodes of care, and the use cases have to be simple, like the low-hanging fruits, starting from appointment triage all the way up to things like post-discharge follow-ups, remote monitoring, and all that. Now, coming to the next point, it's about the right care model or models. See, today, if you see during the COVID peak times of COVID, I think in the US, the telehealth percentage went up to roughly close to that 50% level, and now it's coming down. The general perception is that the telehealth or telemedicine is a huge opportunity and it's going to stay, no doubts about it. And it's plummeting, but that's going to stay. But the key question that needs to be answered is, when you look at primary care, is virtual first the only model? Or if you want to make it the only model, what do you need to do to make it virtual care first a success? Now that depends on the acuity of the patient, acuity of the disease, the other parameters of the patient, like how easily or with difficulty he can answer the or converse with a physician when virtual care is being made. You need an interpreter or you need a kind of a navigator to be by his side or not. So those things will determine whether you can implement that care to start with a virtual care, or that person has to be undergoing a physical care or whatever it is. And more importantly, when you move from virtual care to then physical care or vice versa, there has to be a seamless transition. So at the right point, the right mode of care that's needed should be provided. So that was the other thing that I had. Now, when you move beyond these things that I have on this to slightly high end things, the first thing that I have on this page is precision public health. Now, precision public, we have been talking about precision medicines and evidence-based medicines, but precision medicines is supposed to be treating, some complex conditions of some, so for example, a rare form of brain cancer or a rare form of heart disease for that matter, something which is to do with a rare genetic disorder. That's going to be costly. But if I go back to the statistic which I presented, and if you have 80% of the population 80% of the treatment going towards population having one or more comorbidities, say, for example, in the US, or let's say India becoming the diabetes capital with a vast spread with different levels of the disease or progression of the disease. If you segment that data, you will get layers or strata of that population. Now, what happens is when you look at that strata of the population and you make the right when you use data, when you use evidence, when you use logic, then you can get a set of care protocols which are driven by logic, a set of medications which are driven more by what's working versus what's not, and not necessarily whether it's a costly or a cheap medicine. And similarly, the other interventions that needs to happen. And this can be enabled by the data that's getting generated because of immense focus on on primary care. Now, precision public health obviously is a little bit controversial topic, as I know, because there's always a sort of a argument on precision medicine or precision public health. But in my opinion, when you look at the population, when we need to stratify it and go for the data, this is very important. The other thing that I have is data or information around social determinants of health. Now, it's not that social determinants of health are not at play. For example, there are health payers that actually are tying up with the Ubers and Lyfts of the world to ferry, patients that don't have conveyance to the hospitals when they need a checkup or stuff like that. Or, for example, there is some, before a flu season, they'll be provided with some, probably some of the things to better take care of themselves. Now, that said, what I'm trying to emphasize on is, can we look at a set of, with significant use of data, can we look at a system which throws open, like this is the vulnerable population, which you need, like, you need to help them with pickup of grocery stores because, you're taking medications, but you don't have food in your refrigerators. Or, for example, you need 5 checkups and you're probably not able to drive to the hospital or whatever the case may be. So I'm talking of this at a very, very large scale. And that could actually prevent catastrophes from happening due to either postponement of care or certain medications which are not in, you don't get the medications at time or whatever it is. Now, the last point that I have is beyond the hospital setting. Now, I think COVID-19 has shown us the way, and increasingly, care outside the walls of a hospital, 4 walls of a hospital, is going to become more pronounced. But the challenge there is, the moment there is a hands-off from a hospital or from a treating physician, when it changes hands to a caregiver, the caregiver should be well empowered and enabled to do justice when he is actually, with the patient. And a caregiver could be a community worker, a navigator, or a kith or kin, whosoever it is. Now, one way is basically giving a standard set of protocols to be followed, but that doesn't necessarily work because it's not personalized. It is not very specific to the case that's being presented. So how can this be done? How can technology actually look at what is going well, what is going wrong, and make this kind of care beyond a hospital setting more precise, more reliable, and not lead to adverse events. And that's the that's particularly the purpose of why you provide why you have caregivers. So that's all I had for my my piece of the speech or talk, whatever you say. Now, before I leave it open to question answers or hand it back, I would just like to give a little bit view of our of the startup which I've co-founded. So SPECOR stands for Satisfied Patient and Ease of Clinic Operations. Our vision is to enable, empower, and facilitate healthcare providers for improving accessibility, reliability, and quality of care delivery through digital healthcare solutions, typically AI/ML, both in physical and virtual space. So, and one of our objectives is to significantly empower the primary care physicians, the PCPs, GCs, the small practices, for that matter. And I'll be happy to talk offline with those of you that are interested. Now, having said that, I'm done with the presentation. I'll hand it back to the host, and I'm open to take up any questions or views or recommendations that you may have had. Thank you for patiently hearing me out.
Yes, Miro, thank you for a wonderful presentation. I had a blast. So correct me if I'm wrong. As far as I understand, you are concerned about the overall level of digitalization, but you don't want to rush at it. For instance, some maybe some skewed data come to the centers, and many, very obviously, many variables out there. So you don't want like the data to be skewed. You want it to be grasped from all the sources and everything to be taken into account, right?
Yeah, so typically there are a couple of things. Now, digital is healthcare hasn't been as as aggressive as other industries, but it's nothing new. Digital has been there for the last, you can say, at least a decade, as far as I know, or even more than that, in different forms. Now, what's happening is it's getting accelerated. What I'm trying to say is, if you look at primary care encompasses the basic form of care, and it starts with the rudimentary level of care. And the way you take digital to care at the grassroots at the rudimentary level, you need to look at a set of attributes and a set of things which I just talked about. So that's the only point that I'm trying to make.
Yeah, yeah. I totally understand you. So basically, it has to start with like the most simple, the most basic things,
Yep.
and that's the only way it has to be built in your own in the right manner, I guess.
Yep.
Um, I don't know. I think like that would be it for us, unless like there are any more questions. But I really enjoyed your report, and I've visited your website of your startup, and I think like it has a lot of potential. And thank you so much for joining the summit and sharing this knowledge with us. Uh, so probably that would be it for us. I don't know, I don't know the correct way to say goodbye to you, but except for expressing the great gratitude for opening the second day of our summit. It was a real, uh, I guess, most of our users got some useful insights, and hopefully, the things would change in a way that we perceive some information, and we will try to build artificial intelligence and machine learning ways around in the correct way, at least what we perceive as the correct way, at least what you perceive as, because I'm a complete noob at healthcare, unfortunately, but I can understand the the worries that you're expressing and the worries you try to share with us. Uh, is there anything else you would like to say as a farewell note?
No, thanks again. I would definitely thank Glorium Technologies for hosting me as a speaker over here. And I also feel the audience might have had some takeaways for it. And if anyone wants to get in touch with me, I have my email, my LinkedIn, and all these things are up to date. I check my LinkedIn messages quite often. So I'll be happy to connect with anyone who's interested to have offline conversation.
Yeah, obviously. We will share the link. I guess we have it on our website. If you want, we can insert it into the chat or of.
Sure.
Yeah, networking connections. That's what this summits are all about, and also trying to get some new knowledge and hopefully invest some money maybe and stuff like that. So thank you one more time for this wonderful event